Hi, everyone. My name is Rami Tadros, and I'm the site director of endovascular aortic surgery for Mount Sinai Hospital. And I'm here to talk about the role of intravascular lithotripsy for large bore vascular access and whether a protocol is needed. My disclosures are as follows: Gore, Cook, Medtronic, and Abbott. I serve as an educator and consultant. Some background: large bore access is needed for a variety of procedures. EVARs, TVARs, fenestrated and branched EVAR, and TAVR, Impella. And calcification is a major roadblock to these procedures. It's a major roadblock to success. As you can see in these two cases, in the bowl, that's a common and external iliac artery that was avulsed from a patient due to access issues. And on the right, you can see an iliac on a stick. That's an E-sheath with a severely calcified iliac artery. And you can actually see the calcific plaque here in the center of this image. So the road to success is hard. And I mean that literally, in that when vessels calcify, they become like cement or bone. The pathophysiology behind vessel calcification is very complex, but it involves the differentiation of vascular mesenchymal stem cells into osteoblasts that then deposit calcium in the vessel wall, in the intima and media. Vascular calcification results in a loss of elasticity and compliance, as well as stenosis. And large bore access in diseased vessels can lead to many complications, such as dissection, stenosis, embolization, or worst of all, vessel rupture. Increased lesion complexity results in increased risk. The intravascular lithotripsy system was developed by Shockwave, and that modifies intimal and medial calcification using pulsatile sonic pressure waves. A balloon, because it opposes the vessel wall, is a very efficient and effective way to treat calcific vessels using lithotripsy. Lithotripsy was first developed to treat kidney stones more than 30 years ago and was done extracorporeally. And now we have this system which allows us to use lithotripsy within the blood vessel wall. The energy profile has been optimized to treat vascular calcification. The Shockwave system involves a handle which activates the system, a generator which creates the energy, which is then delivered to these emitters within the balloon. The emitters create energy which expands and collapses a vapor bubble, creating short bursts of sonic pressure waves. The sonic pressure travels through the vessel with an effective pressure of around 50 atmospheres. The localized field effect within the vessel fractures intimal and medial calcification. As the energy is delivered through the emitter, you can see the steam bubble expands and then collapses, generating that sonic pressure wave. And the great thing about lithotripsy, and what's really important to its mechanism of action, is that it is hard on hard structures and soft on soft structures, meaning that it's very effective to fracture calcium, but it does not impact soft tissues in any negative way, which makes this ideal to treat vascular calcification. And by treating the vascular calcification, we can improve vessel compliance. Here, you can see this calcified superficial femoral artery in a cadaver, pre-intravascular lithotripsy, without any fractures in the calcium. Post-intravascular lithotripsy, you can see these fractures within the calcium, resulting in increased vessel compliance. Here you can see histologic specimens as well as CT and micro CT. And you can see this magged up view of the fractured calcium here on histology. And on micro CT, you can see the calcification fracture on both of these images here. So this is the Shockwave system. Again, you have this generator. You have a cable connector that allows you to attach the handle to a balloon shaft. You have a button that you press to activate the system. The system activates in 30-second bursts and then needs about 10 seconds to recover. And then you can activate for another 30 seconds. And again, it delivers the energy to multiple emitters along the balloon length. So utilizing this system, our team at Mount Sinai studied the utility of this to facilitate large bore access in our population. We looked at patients that were undergoing TAVR, TVAR, fenestrated EVARs, and EVARs, and looked to see if it improved our ability to perform these procedures. It was a retrospective study. We looked at patients in our initial cohort from 2018 to 2019, which encompassed 9 patients. Since August 2019, we've done well over 50 more cases and are looking forward to publishing our newest series. Preoperatively, all these patients were assessed using centerline 3D reconstruction imaging using Terra Recon. We looked at the degree of calcification, whether it was circumferential or partial. We looked at the minimum inner luminal diameter. We looked at the maximum luminal diameter. We looked at the total aortic, total vessel circumference, and the length of the calcified lesion being treated. The mean age was nearly 80, with our oldest patient being 97, and the majority were men. We had 100% technical success with 0 postoperative morbidity or mortality. The mean length of the lesions treated was around 4 centimeters, and the maximum diameter pre-treatment was around 3.3 millimeters, with luminal gain of an additional 3.6 millimeters to achieving a vessel lumen of nearly 7 millimeters post-treatment. No embolic filters were needed, as the majority of these cases were done through cut down, and we had no distal embolization. This is an example case of a 62-year-old woman, smoker with very calcific vascular disease and a large AAA. You can see the iliac artery pre-treatment and post-treatment, and you can see the net result of lithotripsy. This is a summary of the patients that we enrolled into our study. And you can see all of these patients here had more than 50% calcification of their vessels. You can see the pre-treatment minimum luminal diameter, and then you can see what size system we were able to deliver through the vessel post-treatment. So, summarize, intravascular lithotripsy improves the vessel compliance and allows us to treat numerous conditions across multiple specialties, EVARs, TVARs, fenestrated EVARs, TAVRs, Impellas, and again, it's through the improved vessel compliance and elasticity. Now, what's really important is that the challenges that we face with large bore access can be identified with baseline imaging, and this really highlights the importance of high quality preoperative imaging and planning. Peripheral arterial disease will become an increasing concern. The population over the age of 65 is expected to double by 2050. The number of endovascular interventions that we are performing is continuing to grow. And so clearly protocols are needed to manage complex vascular access issues. Currently, this is where we implement intravascular lithotripsy. Any vessel that is less than 6 millimeters in luminal diameter with circumferential calcification, or any vessel that's less than 5.5 millimeters with greater than 50% calcification, we consider the use of intravascular lithotripsy. Although a 6 millimeter lumen seems like it would be okay, when we're, for example, performing a TAVR procedure with an E-sheath, for example, that E-sheath is expected to expand to accommodate the valve. If you have circumferential calcification, the valve sheath may not expand, preventing the valve from safe delivery. And we've had situations where the valve gets stuck in the sheath. So To summarize our protocol, we pre-screen all large bore access cases using centerline. We have a team approach: cardiologists, vascular surgeons, cardiac surgeons, and radiologists. We carefully select which patients will undergo cut down versus percutaneous treatment. We pre-treat all access with a 7mm by 60 shockwave balloon. We then pass a dilator to ensure the path is clear. We place the sheath of choice. For example, with a Medtronic valve, we often will use a Gore sheath, 18 French or 20 French. And with the Edwards valve, we use the E sheath. And when we place an E sheath for valve placement, we often will treat stenotic segments with a balloon by ballooning the sheath itself. And that helps facilitate valve delivery. Thank you.